Good morning. Thank you for giving me the chance to present one of our cases. My name is Mahmoud Shoaib from Egypt. This is one of the cases I have assisted in under supervision of my professor Mohammed Shaddad. In our center, we usually do single stage embolization for small arteriovenous malformations like this frontal occipital AVM. This is lateral vertebral angiogram pre and post embolization images. And like this frontal AVM pre and post embolization images. But for larger AVMs, we usually do staged embolization. Like this posterior frontal parasagittal arteriovenous malformation pre and post embolization images showing partial obliteration of the nidus. And like the case we will show, our case today is a male patient aged 31 years old with headache and intractable epilepsy. CT brain of the patient showed this hyperdense lesion on the left side. MRI of the brain showed left posterior frontal parasagittal arteriovenous malformation. CT angiography showed the feeding arteries from the pericallosal and callosomarginal arteries, and also showed the venous drainage, which is superficial to the superior sagittal sinus. The decision was to do staged embolization followed by surgical excision of the AVM. This is lateral internal carotid artery angiogram pre and post embolization images showing partial obliteration of the nidus. We did embolization through the callosomarginal artery only. This is the AB view of the internal carotid artery angiogram. This is the AB and lateral fluoroscopic images showing onyx cast strictly intranidal. Actually, we had a complication intraoperative where the microcatheter caused perforation of the nidus. This is CT brain of the patient post-operative, showing some leakage of the dye in the brain film and showing onyx cast in the bone film. But fortunately, the patient went well and was extubated with no neurological deficit. The problem occurred on the third post-operative day. On the third post-operative day, the patient was discharged from the hospital. He came again in the evening following one attack of convulsion with right side hemiplegia, dead hemiplegia grade 0. CT brain of the patient showed the deep intracerebral hemorrhage deep to the nidus of the AVM. The patient was operated on the next day in the morning by microsurgical evacuation of the hematoma and excision of the AVM. This is CT brain post-operative after the second operation. The patient recovered well with improvement in the motor power. After 4 months, the patient was nearly free. This is MRI 4 months post-microsurgical excision and MRA 4 months post-excision. We have discussed this case many times. We thought if this complication was related to intraoperative perforation of the nidus, the hemorrhage should have been present immediately post-embolization, but the hemorrhage occurred on the third post-operative day. So we thought that this hemorrhage is related to hyperperfusion injury, and that partial embolization of the nidus is not a guarantee or a protection against occurrence of hyperperfusion injury. Thank you.
Thank you. It's pretty much difficult to answer the question because you have two things that are intermingled together. You know, you had a perforation during the treatment and then you had 2 days later a new bleeding. Does it come from the same perforation because it has reopened? Is it the same bleeding originally speaking, or is it a new bleed? So it's difficult to know. Second, we have no angiogram to analyze the architecture of the AVM after the embolization you did. So it's difficult to answer the question, honestly. Is there anybody who has an idea about the potential answer to the question that has been asked?
Question there.
It's looked like venous thrombosis.
Well, but we don't have any angiogram, so we don't know.
Maybe we can see, we could see correctly the post-operative angio.
But there is no post-operative angio.
But the vein is patent in the post-embolization angiogram. The vein was patent. The draining vein was patent.
Well, it's patent, but it might occlude after if the
Yes.
slowing of the flow
Yes.
is important.
Yeah.
This is the only picture you have?
This is the only lateral, and this is the only AB.
Mm.
There is some onyx in the vein.
You know, honestly, in this situation, I mean, you started the procedure as a pre-surgical process, right?
Yes.
Okay. And maybe in that case, it was a problem because, you know, it was not a big AVM, so you could have continued, occlude the vein, and get rid of everything at the same time.
Yes.
If you leave the part of the nidus, you slow down the flow, you don't give heparin to the patient later on, you might get thrombosis of the vein later on and then have this complication.
Yes.
Okay. I have a question, please. Why you discharge the patient from hospital? Why you just go to the surgery? Waiting for what?
We usually do staged embolization. The patient was discharged and will come after 3 months to do another DSA and do second session of embolization followed by surgery.
But you get complication. You get perforation of the nidus. You get partial embolization. You should not wasting time.
Because the patient was extubated with no neurological deficit.
No, but stage procedure is a way to deal with big AVM. I mean, in this case, it's a little bit doubtful because it's not that big. But, you know, you have to stage the treatment of the AVM. If it's too big,
AVM, you
otherwise
can
it's
stage
big.
it is small, and he perforate the AVM, and he terminate the procedure urgently. He cannot continue the procedure.
No. Usually, it's very frequent that you have a rupture during the embolization, whatever is the liquid embolic you are using. There is no bleeding. It means that the embolic agent is going outside the nidus, but at the same time you have a sealing of the leakage. So there is no true bleeding.
I know there is no problem from the leakage of, but he does not continue embolization of the AVM. He stopped the procedure without finishing all the AVM embolization, only partial embolization of the AVM. So you cannot, maybe there is venous congestion from the side, by time it will get ruptured. So why he don't go to the surgery and eliminate this risk?
No, you are right, but you know, there is the theory and there is the practice. Sometimes in a practical way, you cannot achieve the goal you intended to get. So probably, I don't know what was his goal. And you know, maybe he started with the idea to do a partial treatment and then to stage the procedure and then to do another session. Now, in between, after the treatment of the first session, he didn't interpret exactly the role or the interaction with the venous system. So maybe this is the reason why the patient got a bleed later on. Or maybe he was not in the condition to continue. I don't know the way it has happened. But you know, he started with the intention to do a first session, followed by the second session after a few weeks. And he had in the middle something that he didn't control, which was a progressive occlusion of the venous system.
Of course.
You know, you are not always controlling everything,
Yes.
so probably this is what has happened to him.
Of course, this AVM can be managed surgically from the start without embolization, but this was our decision.
No, but you know, if you think about the strategy, the first question is, should you treat this brain AVM which has never bled, which is a major question, you know.
Yes.
Hero, please.
Jacques, Nasi Kocher and Michel Mawad both now talk about embolization and excision under the same anesthetic. From the cath lab or neuro lab, the patient goes to the OT and so they are saying that more and more they believe in this. So what is your take on that?
If you have a good friend who is neurosurgeon and who wants to take the decision to be responsible of the deficit of the patient, it's a good way to proceed. Because as far as you embolize, you don't wake up the patient and you send the patient to surgery. The complication belongs to the surgeon. I don't think it's a way to go, unless you are in a bad condition and you need an excision because there is a problem during the procedure. Otherwise, you have to take your own decision and to face your own problem. So, you know, it's a way to throw the ball to another guy. Yeah?
And the logistic is not easy to organize because the neurosurgeons, they have to wait until you have completed your embolization. So they don't like too much waiting for you. So it's, in our institution, it's almost impossible to organize.
And then it's a long operation because even if it's a remnant, excising an AVM is still a painful operation.
Yes?
May I ask? Is this concept of hyperperfusion post-AVM embolization, are we over-theorizing it, or does it really exist? In most of the cases, it might be just the venous occlusion or some of the other reasons which may be the cause. So what is the concept of hyperperfusion after the AVM embolization, and we hold them as responsible?
What do you mean by hypoperfusion concept?
That's what they have suggested. Does it really exist? That's what I wanted to ask.
You mean bleeding on ischemia? No, it's honestly, I agree. The reason of the bleeding is probably a venous occlusion.
Can you answer?
It's only one of the possibilities we thought about. We are not sure.
Hello, here.
What exactly is the concept?
I think that the one you're talking about is the normal pressure perfusion breakthrough. Is it?
Does it really happen?
I don't think it happens. I don't think it happens. We close up high flow fistula, but we never have that. I think it's a neurosurgical problem because they hurt the veins, but they don't realize.
And usually it's described for much larger brain AVM than this one.
Not this one. Okay, my question, he was asking about the cause of the delayed bleeding 3 days after the procedure. I think the bleeding that happened is in the deeper part of the brain, so I don't think it's likely to be caused by the perforation of the feeder or the nidus by the catheterization, because it should be more superficial to start with. And so it must have been the venous occlusion. And every time you have some complications, I think it would be a lot better to get all the information you can get, even though you want to go to the surgery. Maybe perform an angiogram will give you the answers and some assessment to improve your strategy the next time, I think.
Yes.
Okay.
Hello, here.
Yeah.
Do you know how is the arterial blood pressure? Because I think a systemic cause of the bleeding always that we occlude an AVM, I think a small AVM, and collateral vessels always open, and plus this with a systemic hypertension, I see in other cases that it's gonna bleed. I don't know how is the arterial blood pressure of this patient.
Yes.
In the post procedure, of course.